So our next speaker is Dr. Yvonne Dimitropoulos, who is a research associate here at the Poche Centre at the University of Sydney. She's a registered oral health therapist and just completed her PhD in co-designing oral health promotional programs for Aboriginal children in rural and remote communities. And today, Yvonne will be presenting on scaling up fluoride varnish programs for priority populations, including Aboriginal children. Over to you, Yvonne.
Thanks, Tom. Okay, let's share the screen.
She's a bit new at this, so you have to bear with her.
Yeah, just returned from maternity leave. It wasn't that recent, but
No, I mean, how to work this system.
yeah. So thank you, Tom, for that introduction, and thank you for all your support and hosting today. Before I begin, I would like to also acknowledge the traditional custodians of the land on which we're meeting, the Gadigal people of the Eora Nation, and pay my respects to elders both past and present. Also, just before I begin on my presentation, I just want to say thank you to all of our presenters who have presented and supported the showcase. Thank you for your patience while I've been emailing you all, and thank you for our audience and the questions that keep the showcase going. Today, as Tom said, I'll be presenting on our work scaling up fluoride varnish. It's a team effort that myself, Dr. Kylie Gwynn, and John Skinner and a team of researchers have been working on for several years to provide school-based fluoride varnish applications for Aboriginal children. So, for those of you that might not know, the regular application of fluoride varnish, which is a concentrated gel of fluoride, that if it's applied 2 to 4 times a year, can prevent dental caries by up to 43%. And we know Aboriginal children have a higher rate of dental caries, often experiencing double the rate of dental caries than non-Aboriginal children. We also know that many Australian public health policies recommend the development and implementation of fluoride varnish programs for priority populations, including Aboriginal children, like the National Oral Health Plan or the New South Wales Aboriginal Oral Health Plan. However, despite these recommendations, we know that little progress has been made, and that governments and public oral health services tend to favour treatment-based approaches. We also know that Aboriginal children might not access these mainstream services. They're accessing more emergency restorative work. But we do know that Aboriginal children go to school. So our fluoride varnish programs bring an evidence-based caries preventive service to Aboriginal children in the school setting. That's through a program that was co-designed by the Poche Centre and Aboriginal communities 6 years ago. And it's been providing Aboriginal children in rural and remote communities with fluoride varnish every 3 months for 6 years. The program was co-designed at first. Aboriginal communities in central northern New South Wales wanted non-dental professionals, so for example, community members or teachers, to apply fluoride varnish, as they believed that would be the most suitable. At the time, that wasn't possible, so we relied on oral health therapists to apply the fluoride varnish. And behind the scenes in parallel, the Poche Centre was working on a pathway to enable Aboriginal dental assistants to apply fluoride varnish. After a couple of years of the program, we were able to enable dental assistants to apply fluoride varnish, but that was under the supervision of an oral health therapist, and a caries risk assessment needed to be completed. And while that was great and a great step forward, it wasn't consistent with a public health approach, and it was not the most sustainable or cost-effective option, especially in communities with limited dental services. Which brings us to this study. So the aim of this study was to scale up that fluoride varnish program into urban schools, so moving from rural and remote communities where we know this program was doing really well, and scale it up in urban communities using a public health approach. We also wanted to better understand how the scale up process could be done effectively in a school-based setting using that public health approach. We know that fluoride varnish can be scaled up on paper. Dr. Skinner has demonstrated that this model can be implemented and scaled and be financially covered under the Child Dental Benefit Scheme. But we wanted to better understand that scaling process so we could recommend this be implemented as the core business for oral health promotion for oral health service providers. So using our public health approach, it meant that all schools were invited to participate based on priority population data, and that all children from those schools were invited to participate and receive the fluoride varnish, irrespective of their individual oral health status. So that the way we identified if the population was a priority population was looking at the socioeconomic status of the school. And that was the ICSEA score, Index of Community Social Education Advantage, and the percentage of Aboriginal enrolment. Schools that were in Western Sydney and Sydney that had an ICSEA score less than 1,050 and an Aboriginal enrolment of greater than 12% were invited to participate. That was a total of 18 schools that met that criteria. 4 fluoride varnish days were held at the participating schools between May 2019 and December 2020. And it was one per school term, so every 3 months. A follow-up fluoride varnish day was also scheduled to follow up children who were absent. Both Aboriginal dental assistants and oral health therapists were used to apply the fluoride varnish, and fluoride varnish was applied to all children with written consent. So we removed that step of the carer's risk assessment, which was consistent now with the public health approach. So out of the 18, 6 schools agreed to participate in the study and were included, and that was a total of 791 children. And they from 6 schools and were offered the program. 225 students, so about 28%, returned a consent form, and 96% were eligible to participate. The only reason for not being eligible to participate was uncontrolled asthma, as reported on the consent form, and uncontrolled asthma is a contraindication to the application of fluoride varnish. That was the sole reason children were excluded. The school consent response rates range from 17 to 80%, with an overall consent response rate of 28%. We found that schools that engaged an Aboriginal education officer, so the link between the community and the school, was schools that had a higher consent response rate. And majority of the students, 57%, identified as Aboriginal or Torres Strait Islander. Majority of children, 80%, received at least 3 fluoride varnish applications over the 18-month study period, with 35% receiving all 4 applications. No adverse reactions were encountered during the fluoride varnish program, and this just confirmed that Aboriginal dental assistants can safely apply fluoride varnish and irrespective of using a carer's risk assessment or not. This is one of our Aboriginal dental assistants who was fantastic and really took it as part of her role and responsibility as not only an Aboriginal dental assistant, but someone from the local community providing a much needed dental service. So what we found was that this fluoride varnish program that we've been implementing in rural and remote communities for many years now can be scaled up into urban schools, and a public health approach can be used. So all children are receiving the fluoride varnish, irrespective of carer's risk. It provided children in a priority population including majority Aboriginal children, Torres Strait Islander children, 3 to 4 applications of fluoride varnish. This meant that Aboriginal children who might not necessarily access preventive dental care are not only receiving a preventative dental care, but receiving the full benefit of something that's evidence-based. So really getting 3 to 4 applications, not just 1. That's maximising the carried preventive effect of fluoride varnish in a culturally safe setting. We did encounter some barriers in the scale-up process into an urban setting that we haven't encountered while implementing this program in rural and remote communities. That was the first one, was agreement on whether an oral health therapist or dental assistant should be used, and that was agreements between local health districts. And in the end, we just went with a combination of what was suitable in the local context, so both oral health therapists and Aboriginal dental assistants. And at the same time, the New South Wales Health Primary School Mobile Dental Service Program, which is New South Wales Health, a van that goes and provides dental treatment in schools, commenced in 3 out of the 6 schools. This duplication of oral health services, we've not encountered that in rural and remote communities before. And it caused some confusion for the schools that had 2 service providers attending the school. It caused some confusion, and that confusion can impact on the acceptability of something coming into the school. We all know that schools are so busy with their curriculum already, and that having just the confusion around that could really impact on them agreeing to keep doing that and having the school, having the oral health service at the school. So, and that can impede on the provision of evidence-based dental care for children that are not, might not otherwise receive dental care in a mainstream health oral health setting. So that can be prevented by clear communication channels and between service providers to make sure that there's no duplication. So just to conclude, fluoride varnish can be routinely applied for priority populations in an urban setting using a public health approach. And we recommend that it should be included in the core business of public oral health services to assist in the prevention of dental caries for children, including Aboriginal children living in urban New South Wales. So thank you very much. And again, thank you to all our presenters and audience.
Questions come through. So great work, Yvonne. Sorry if I missed this info, but what proportion of children who signed up were Aboriginal? What was the consent process appropriate?
Yeah.
So 57% of the children was that were enrolled into the program were Aboriginal, and the consent process was a written consent form that was given to the school, and an Aboriginal education officer worked through that consent form with parents and families. It was up to the school if they had offered the program to all of the students or just Aboriginal children. In the bigger schools, we found that they offered the program only to Aboriginal children, but in some schools it was offered to both Aboriginal and non-Aboriginal children. So there was a large proportion of children that were identified as Aboriginal and Torres Strait Islander. Hopefully that answered your question.
Yeah, and there's been a number of publications associated with this.
Yeah.
And you might want to mention about you know, the work that you and John have been doing to lobby the jurisdictions to get them to come on board.
We've been doing a lot of work nationally to the word is not coming to my brain right now, for consistency of the fluoride varnish programs across Australia in different jurisdictions. There's different regulations on who can apply fluoride varnish, and in some jurisdictions, for example, before in New South Wales, it was only registered medical and dental professionals, which is really problematic in some rural and remote communities where there is a shortage of registered medical and dental professionals. And so trying to expand who can apply fluoride varnish and have a consistent approach to the routine application of fluoride varnish. We've had a lot of interest in partners from the Northern Territory, from Victoria, from Tasmania, which is where we got a lot of this from. They systematically work through schools in priority populations and just go in and offer fluoride varnish and fissure sealants, which are some preventative small fillings we can put on the teeth to prevent tooth decay.
So that actually, there are two questions, and I will come to yours, Carwyn, in a moment. But first of all, Liz Elliott has asked, would this be likely to be able to be offered in Fitzroy Crossing? So that's NT.
Yes, definitely. And that's the beauty of the program, is that it's very simple. Non-dental professionals such as dental assistants or Aboriginal health workers can apply fluoride varnish, and it's a one-page protocol that we work together with New South Wales TAFE, that it was a 2-day course to train them to apply fluoride varnish, and then just a one-page protocol on going into schools and applying the fluoride varnish. It's the fluoride varnish is put on to children who are just sitting on a regular dental chair. There's no need for fancy equipment. It's just the fluoride, PPE, so masks, glasses, the fluoride and a little brush to put it onto children. And so if you're open to collaboration, we can definitely work on that.
And so it is, the West Australian associations have approved it?
Western Australia?
Yeah.
I don't know. Maybe John can comment.
That's what we'd have to check out, because on who can apply.
Oh, yes, definitely. In the Northern Territory, Aboriginal health workers can apply fluoride. Yeah, definitely.
Carwyn has asked how the work was funded, including the oral health products used in the study.
So the funding was from an MRFF grant, Medical Research for the Futures Fund grant, the application that we won, and then the products were then obtained from Colgate, from Durafat.
You can choose your flavour that you want.
Yeah, we stick with original because the kids like it.
Yeah.
Thank you.